Welcome to our birth advocacy policy making webinar. Um, I'm Sam, ICAN's current VP, leader of the San Francisco East Bay chapter. And I am so thrilled that we have Jill Alleman from the American Association of Birth Centers with us today to talk about all of the advocacy that they are doing. And I'll let her introduce herself.
All right,
Take it
great.
away.
Thank you. Thank you, Sam. So I'm Jill Alleman. I am a midwife. I've been a midwife since 1986. Most of my clinical years I spent in freestanding birth centers, most of that in rural East Tennessee. That's where I live. And once I retired from being on call in clinical practice, I became a faculty member teaching nurse midwife students at Frontier Nursing University. And I also serve in a volunteer role as the chair of the Government Affairs Committee of American Association of Birth Centers. So in that role, I do work both with legislation and work with policy work, working with federal and state agencies. And you know, we work on getting bills introduced and passed, and we also work with various states that are in the process of working on legislation to remove barriers to freestanding birth centers. You can usually tell whether there are a lot of barriers in your state for birth centers to exist and to operate by the number that you have in your state. So I'm going to show you a map in a few minutes that'll give you an idea of what states license birth centers. So with that, I think I'll go ahead and share my slides and get started with that. Does that sound okay with you, Sam?
That's perfect. Thank you so much.
All right, so I'm going to go ahead and do that then. See if we can get there we go. All right, can everyone see the slides okay? Great.
Yep.
So I'm going to give you a kind of a brief overview of the status of birth centers in the United States. That will be a kind of a smaller part of my presentation, and then I'm going to get to some of the bills that we're working on right now to increase access to midwifery care and to birth centers. And I do want to allow plenty of time for questions. So this is just kind of some background information that I thought might be helpful, because I don't know how many of you have actually visited a birth center, used a birth center, or interact with freestanding birth centers in your area and in your state. So the definition of a freestanding birth center is a healthcare facility where care is provided in the midwifery and wellness model. And I think that that's really an important statement. When you think about the model of care, it is really different from the traditional or typical medical model that we see in most of the US. So this is a place where the birth setting is freestanding. It's not a hospital, so that's made clear in our definition, because some hospital labor and deliveries call themselves a birth center, which is confusing to consumers and providers alike. So we believe that the birth center should be fully integrated into the healthcare system. And this is one of the challenges that birth centers face in most states. There are a few states where birth centers are getting to be better integrated into the overall healthcare system, but this is still one of the challenges. And so, you know, we're looking at real family-centered care, use of medical intervention only when it's appropriate, cost effectiveness. So we like to say, you know, where the practice of midwifery and the support of physiologic birth and newborn transition may occur in other settings, it's the exclusive model of care. in the freestanding birth center. So it's what we're all about. It's not something that our clients have to fight to get when they come to a birth center. It's what they expect as the norm. And we're all about respect for the woman or other childbearing person's right to make informed choices. The family, as they define it, is welcome to participate. And that's who participates is totally under control of the laboring, the pregnant person. So, you know, I used to think about personalized, person-centered care as a goal, but once you've seen the care in the birth center, it really is the norm there. Just a couple of other points that you may or may not be familiar with. There are standards for care in birth centers, and those are evidence-based. They're updated as needed by panels of stakeholders and experts. And this is the sort of the way we measure the quality of the care in the birth center. And the birth centers may or may not be accredited. Some states require accreditation, and some do not. So the American Association of Birth Centers sees this as the gold standard for care is accreditation using the AABC standards. The CABC sets indicators that birth centers show compliance with when they go through the accreditation process. So birth centers, the standards are by AABC and the accreditation is by CABC. So the number of birth centers was fairly level and very slowly growing through the 80s and 90s. And then they really started taking off starting around 2010 with consistent growth in the numbers. And currently there are about 400 birth centers in the US. This still represents a very small percentage of all births in the US. So we're talking about 0.65% in the last year that's been reported by the CDC, the vital statistics. But that does represent, even though it's still a very small percent, less than 1% of all births, it's a 100% increase in the last 10 years. So I'm sure you're aware of the definition of community births, which includes home births and birth center births. So community births represent a little over 2% of all US births. So there are about twice as many births in homes as there are in birth centers. You may not be aware of that. The highest increases that we've seen in those recent years have been typically among non-Hispanic white women. However, beginning in 2021, we started seeing significant increases among non-Hispanic Black women. So that's been a growing trend. And of course, the research does support improved outcomes for non-Hispanic Black women with birth center care and birth center admission in labor. It greatly reduces the risk for C-section and other morbidities. If you look at who the providers are in birth centers, it's as you'd expect. The providers in birth centers are midwives. And so just looking at the breakdown, it's pretty much half and half between nurse midwives or certified midwives, which is the non-nurse midwife that is mainly located in the Northeast. As far as their, not all states license CMs yet. They take the same certification boards and they have a master's degree like nurse midwives. So that's about half, and then about half CPMs providing care in birth centers. The fastest growing model of midwifery providers is the birth centers who are staffing both CNMs and CPMs because of the skills and benefits that each type of midwife brings. Only 1% of birth centers use physicians. So there are physicians who are attending births in birth centers, but it's very small percent. So I'm sure you're all very aware of the status of maternal health in the U.S. that, we're ranked worse of all high resource countries. We spend more money, but we're just not doing well in our outcomes for either maternal mortality and morbidity or infant mortality. We're just 55th in the world. So that's even lower than some low resource countries at this point. And then we have the racial disparities. The highest risk group for maternal mortality is American Indian, indigenous people, and next is African American population groups. And then we have Medicaid paying for about half of all US births. So we're not getting good value for our taxpayer dollars or for the way we are really operating our maternity care system in the US. So I just wanted to share with you before we get into the bills, just a little bit of some of the research on birth center outcomes, in case you're not familiar with that. This photo is the outside of the Midwife Center, which is located in Pittsburgh, Pennsylvania. It's one of the largest birth centers as far as the number of people they serve in a year. But birth centers typically serve an average of around 100 births per year. So they're typically smaller. So the Strong Start study was conducted from 2013 to 2000 through to the full year of 2017, and the outcomes were published starting in 2018-19. There were 49 birth centers. There was an arm of the Strong Start study, which was birth centers, and then they had group prenatal care and maternity care homes as the three models they looked at. And the goal of the study was just to see if the model of prenatal care could change or reduce preterm birth rates and low birth weight. So of these models, the only one that really made a significant difference was the freestanding birth center model. So part of this study was to look at prenatal care and get into the details of how to provide enhanced prenatal care that really addresses the social determinants of health and really provides more than just your 10-minute face-to-face time in an office with a provider. So these are just some of the components of enhanced prenatal care that the study was looking at. And most, if not all of these have always been components of prenatal care as it's provided in the birth center. And we think this is one of the key reasons why birth centers achieve the outcomes that we do. So this is just a quick comparison that, of course, is not matched pairs or anything like that, but just to give you an idea of Strong Start in the birth centers, our arm of the Strong Start study. All the participants were covered by Medicaid. They all, we had higher percentages than our usual birth center population of risk factors such as history of domestic abuse, chronic stress, history of depression. Some had previous preterm births. So lower education levels. So it wasn't socially equivalent to the usual birth center group that we've looked at. However, even with that, we achieved really good lower rates of preterm birth with this population compared to the national rates. Everything was pretty much cut in half, and the total C-section rate, primary C-section rate 8.7. When you look at women who'd had a previous C-section, the C-section rate was 12.3%. So really, really good outcomes achieved. And these were not all births that occurred at the birth center. So the important thing to look at here is birth center prenatal care really makes a difference, even if people then choose to deliver at the hospital or be admitted at the hospital. So about half delivered at the birth center and half delivered at the hospital. And when you think about it, we know from our research that just being electively admitted to a hospital in labor greatly increases the risk of having a cesarean section. So because these people had the prenatal care, the education, the support, and were able to develop a relationship with that continuity of care with their midwife care provider, we were able to achieve the lower C-section rates and the reduced preterm birth. So that study has gotten a lot of attention in policy circles, and policymakers and legislators and their staffs have taken a greater interest in improving access to midwifery-led birth center care because of it. This is just one more data slide. I'm not going to overload you with data, but this one just shows the breakdown on these on preterm birth and low birth weight by race, by all races, and by African American. And then it also shows the U.S. Rates for preterm birth and low birth weight for African American newborns in the U.S. And these data are from the time period that Strong Start was going on. So these levels are from 2017. Of course, they're not much better, if any, now. The other thing that was really big about this Strong Start study was, and that we've seen this in other studies, is that there is a very high rate of patient satisfaction with the midwifery-led model of care. So there were focus groups and surveys, and these are just some of the comments that the patients made about the birth center model of care. And my favorite of all is that the birth center, the beneficiaries or the participants felt like the midwives and the birth center providers knew them well. And this is what we believe really makes the difference in outcomes. So we have some challenges with that because we have a model of care that is time intensive. Our visits typically in the birth center are scheduled, a routine follow-up visit for 30 minutes, a new visit for an hour. So it takes time to listen to the pregnant person, to make an individualized plan and develop a relationship with them. So that means that midwives see fewer patients per day. So it costs more at the front end to provide this care. However, if you look just at Medicaid, it saves big dollars because the cost savings come from better prepared childbearing people, healthier breastfed babies that breastfeed for longer, and lower rates of cesareans and other interventions that cost more at the time of birth. So the Strong Start study actually looked at cost savings and matched people with other people covered by Medicaid in their same regions with a similar risk factors, and showed that the cost savings were $2,010 an average for every mother-baby pair over the first year, from birth to the first year of life. So there are significant cost savings, but that really needs to be applied to the increased cost of the prenatal care. So that's one of the things that we're working on now, is trying to improve the reimbursement by Medicaid and by private insurers, because what we see is that birth centers are reimbursed at such a low rate for all this time that they put in, that it makes it hard for them to be sustainable. So we've got a great model. We got to make it work better so that birth centers can continue to operate and can afford to continue to provide the care. So right now we have only a small fraction of Medicaid beneficiaries who are able to obtain birth center care because there are state regulations that limit the availability, and there's Medicaid policies that base reimbursement on volume. You may have noticed this when you've gone for prenatal care. It seems like they're trying to herd people through. I don't know who you went to for prenatal care, but if you've ever been in that sort of typical prenatal care medical model, it is kind of a high volume type of operation. And I'm certainly not trying to doctor bash. We need physicians. We're part of the same team and we work together, but that model really does not lead to the optimum outcomes. Okay, so with that, let's move to the area of regulation law and policy. And I haven't noticed, are there any questions in the chat, or are we're good?
Gonna save the questions for the end.
Doesn't look like there's any questions.
I don't see any questions right now.
Okay, great. All right, so and if you have questions, feel free to write them in the chat or raise your hand, because we can talk about questions anytime. So the first law I want to mention is the Birth Center Medicaid Reimbursement Act, and that was passed in 2010. That defines freestanding birth centers, which is important to have the model defined in federal law. It also states that the birth attendant, who is the midwife, must be covered and reimbursed separately, in addition to the facility itself. Just like when you have care in the hospital, the professional, the doctor or midwife has their bill and gets paid, and then the hospital facility gets paid for their part of the charges as well. So it also mandates that Medicaid reimburse birth centers, and it lists the birth center as a mandated covered service when the birth center is licensed or otherwise recognized by the state. So if it's a state that doesn't license birth centers, they can recognize them in their Medicaid regulation. That's the way North Carolina is doing it currently. And so birth centers have to be paid by Medicaid because if they are accredited in the state, that's the way that state works it. So this is a map that just shows the licensure of birth centers in the US, because each state has to individually agree to license birth centers. We still have a few states who don't recognize or license birth centers, but 86% of states do. Just this year, we've added Michigan, who previously did not license birth centers. And there are states that do license, but had huge barriers. For example, in Kentucky, and the little stars are the requirement for the certificate of need. So the certificate of need is a regulatory process where even though birth centers can be licensed, before they can be licensed, part of their application is to pass the certificate of need process. That's a process that determines whether there is a need or whether having a new birth center open might be a duplication of healthcare services. So there's some states where that's been a huge barrier. Iowa has been one where there have been birth centers that have applied to open, and if they are opposed by a hospital in the area, then the birth center cannot get a license. Even, one of the birth centers that applied was way up here in a rural part of Northwest Iowa, where they did have a hospital, but they had very limited services, and the hospital opposed it. So And that was a federally qualified health center that wanted to open the birth center, but the hospital opposed it, so they could not. Kentucky has been another state where the certificate of need has been a real barrier, and Georgia as well, where they'll have allowed hospitals to oppose and say, we provide services at the hospital, so we don't need this birth center. And that's all it takes to prevent the birth center from opening. But just this year, we have had the certificate of need has just been removed in Iowa. They have passed is a bill that says that they remove the birth center from the requirement of requiring a certificate of need. So that's passed, and it's still waiting on the governor's signature. In Kentucky, they've removed the requirement for the certificate of need for birth centers. So that has been finalized. They are working on finishing up birth center licensure in Vermont right now. And it's in the final stages, but that will remove the certificate of need requirement for them. So in some states, the certificate of need, or CON, requirement doesn't really present that much of a barrier, but in other states, it's a real problem. So we are seeing more and more states remove that requirement. Connecticut just removed it last year. Massachusetts just removed it last year. So there has been some good progress in the certificate of need barrier in several states. So that's one thing that we are seeing. So as I said, Michigan just added licensure of birth centers, and Vermont is about to. They're very close to that process. In North Carolina, as I said, birth centers do not there is no licensure for birth centers in that state. What they have in North Carolina is in Medicaid regulations, because Medicaid wanted people to have access to birth centers. They wrote it into their regulations that if a birth center is accredited by the CABC, then they can be eligible for Medicaid reimbursement. So that's just a method to kind of get around the licensure barrier. Of these states, and I don't think I included the map with the numbers of birth centers. The states that have the most birth centers right now are Washington, Oregon, California. Texas has about a fourth of all the birth centers in the US because their regulations for licensure are very easy to achieve, and they don't have a lot of barriers. However, about half the population is not able to use birth centers in Texas because the Medicaid reimbursement is so low there that only a few of those 90-some birth centers in the state are able to afford to take Medicaid. Florida also has quite a few birth centers. Virginia, even though they don't license birth centers, they allow them to operate. But again, without licensure, they are not accessible to people on Medicaid for the most part. Idaho has quite a few birth centers. I mean, it's less than 10. But again, they cannot, people covered by Medicaid cannot use a birth center in Idaho. Wisconsin has a few birth centers as well. So these and Maine, they allow birth centers to operate, but because the federal law says they must be licensed or recognized by the state to be eligible for Medicaid, there's the 40-some, or in some states higher than 50% of pregnancies are not eligible for birth center care. All right, so what is some of our current policy work for birth centers? Nationally, we're looking at several federal bills, and we have prioritized 3 for this year. The first is the Babies Act. The Babies Act would set up a demonstration model to help improve reimbursement to birth centers, basically. So it would be to start out with, for a 3-year period, it would be 6 states could apply to be the demonstration model states, and birth centers there would be reimbursed based on their cost of providing their care. And this is for people covered by Medicaid. So it's to work on cost-based reimbursement, which is similar to what federally qualified health centers and federally designated rural health clinics are reimbursed by. It's a higher rate of reimbursement by Medicaid, which would allow more people on Medicaid to use birth centers. And then, of course, they could be open to everybody with commercial or private insurance as well. The other part of the Babies Act would set up funding for birth centers to get some startup funding. It's not a huge amount, but it would make some grant funding available for birth centers that are just starting out to do renovation or buy equipment or become accredited. So that's the Babies Act. It's about to be reintroduced in both the House and the Senate. We are getting all 3 of these bills introduced on May the 5th, which is the International Day of the Midwife. And so we're going to have a Hill Day. We're going to have and AABC works collaboratively with other organizations, and that's one reason we're really excited to talk to ICAN, because we know that we have some goals in common, and so several organizations will be participating in a Hill Day that day to celebrate International Day of the Midwife and try to drum up and add more sponsors to these bills as they're introduced for this session. The next bill of the 3 is Midwives for Moms Act, which would provide funding streams for scholarships because we need more midwives. We need to educate more midwives. And this bill would provide funding both for nurse midwives and for non-nurse midwives. And I'll talk about appropriations at the end of that, but there has been funding for midwifery scholarships that are based on this bill every year for the last 5 years. So we're just doing it getting appropriations committee to approve it on a yearly basis. And we're hoping that will happen this year in spite of all the cuts. The third bill is Midwives for Service Members Act, which will also be introduced May 5th. And Midwives for Service Members is a bill that would add 2 other midwife types to authorized providers for military and active duty TRICARE coverage. Right now, the only midwife that is covered is the certified nurse midwife. And as you saw in the pie chart, about half of birth centers are staffed by certified professional midwives or other licensed midwives. And so we just want to make sure that no matter, for TRICARE, birth centers have to be accredited. That's a given. But we just want to make sure that if the birth center is not staffed by certified nurse midwives, but other midwives certification types, that they'll still be eligible. The appropriations funding is something that we work on a yearly basis. And so sometimes what we do is have constituents that are in the areas where we're targeting members of the appropriations committee to reach out to them, to ask them to pass funding. But we actively write to the members of the appropriations committee and ask them to support this funding again. The education of midwives is really key because we have a growing shortage of maternity care providers in this country. ACOG has done their own, they do their own statistics on the OBGYN workforce, and they are actually having more of their members retire than they are graduating from residency programs. And that has been happening for the last several years. So it's a growing shortage, and our population of childbearing people is still slowly increasing at this time. Some of the state licensure and regulations revisions I went over when we talked about the map, but a couple of other really interesting state bills that have passed. In Kansas, they just made birth centers, no matter their ownership type, whether they're an LLC, they don't have to be a nonprofit to be eligible for a liability insurance, a malpractice insurance that is state-based and supplemented by the state. So they just passed a law that birth centers are eligible for that in Kansas, which is a real big help because that can be a big cost, especially to a smaller business size like birth centers are. New Mexico just passed a very exciting bill, which is to, I think I mentioned earlier, to approve or mandate parity for the payment to birth centers to be the same payment that is provided to hospitals for the same level of care. So when a hospital provides a low risk, uncomplicated vaginal birth with a normal newborn, whatever they're reimbursed for that should also be paid at that same level to birth centers. Which, as you know, as I mentioned before, just the length of time that is spent at prenatal care and postpartum care by the midwives providing the care, that alone really gives a need for some payment parity and increased reimbursement. In Hawaii, they have just been updating their birth center licensure and also updating the certification types of midwives who can provide care in birth centers there. They don't currently have any birth centers. They had one, but they're hoping that some more birth centers will open. Michigan, I mentioned, just added birth center licensure for the first time. So we have other birth center bills going on at the state level. It does seem like there's momentum at the state level, and it almost feels like we can get more done at the state level right now with all of the, some of the federal challenges that are going on. TEMA is a project that's being run by the Centers for Medicare and Medicaid Services. It's a long-term project. It's a 13-year project that just started in January. 15 states were chosen, and this is all about TEMA stands for Transforming Maternal Health Care. So it's about providing more evidence-based care and value-based care. So you reimburse the models of care that achieve the better outcomes. We continue to try to disseminate our data and our outcomes. When someone asks us, what studies do you think are needed on birth center care, we're sort of at the point where we feel like the model has been proven to be effective. We have really good outcomes. So we need to continue to disseminate that research. And AABC has always been a big proponent of collecting data. And we have a research committee that is very prolific in getting the studies out there. And then we continue to work with the Maternity Care Caucus and the Black Maternal Health Caucus in Congress. Those are the groups of legislators that are really focusing on these issues. So for the first time last year in May, we actually had a maternity care health fair in Congress. It was just in one of the little side rooms, and all these exhibitors set up, and the staff people came by and met with them and talked to them. So that it's just such an important issue, but it gets overlooked way too much, and it always has. Just the whole health of mothers and childbearing people and babies needs a lot more emphasis in this country, especially with the current status being what it is. So these are the three bills. I already talked about them because I forgot I had these slides in here, but Midwives for Moms, again, is for scholarships to educate more midwives. And since we have been funding this on a yearly basis, we already have midwives who have graduated who have benefited from this funding. We just want to pass Midwives for Moms so it will codify it and make it permanent law, so we won't have to argue to get it every year. The Babies Act, I also talked about. Last year, we were updating the language to add the startup funding for birth centers. Our champion is from New Mexico, Ben Ray Lujan, who covers both the Midwives for Moms and the Babies Act in the Senate. And Midwives for Service members was, we try to always make sure that our legislation is introduced and championed in a bipartisan way, because we believe that these issues shouldn't be partisan. This should be the concern of every American and every person who's representing us in Congress. So Representative Kilmer led the bill to start out with last Congress. He actually had a birth center in his district that was staffed by CPMs, and they had obtained a TRICARE contract, even though they weren't supposed to, because they didn't have nurse midwives. They were providing care. They were one of the only providers in the district, and there's a military base in the district. So TRICARE took their contract away from them, leaving a lot of people stranded. So he championed the bill, then he retired. And so it's being passed on. And this is Juan Ciscomani, who is from Arizona. He is from Tucson. He is more of a moderate Republican, and very, very supportive of midwives and midwifery care. So we're hoping that he will, we're pretty sure that he will co-lead the bill. Representative Kilmer handed it off to another Democrat in Washington State, Marilyn Strickland, who is on Armed Services. So this bill has to go through the Armed Services Committee. We're hoping that it might move this year, because the Defense Authorization Act passes every year, almost, pretty much. And so if we can get this bill introduced, they might just fold it into the Defense Authorization Act. So that's our hope, to get that bill possibly moving this year. This is a group of state advocates from Massachusetts celebrating their big win. In 2024, they passed the first segment of their bill called had a lot of factors in it, so it was called the Momnibus bill. And it's a play on the words omnibus, the Momnibus bill. So Massachusetts is really working hard to integrate midwifery and birth centers better into their whole healthcare system and achieve pay parity for the midwives. And I've already mentioned these other states that have had big wins. Again, we're just seeing momentum at the state level right now. And so there are opportunities for other interested stakeholders in the states to get involved, and even just call your representative and ask them to co-sponsor a bill. This just talks about some of the things that they've done in the Momnibus, some of the things they're still working on. They added licensure for CPMs, reimbursement parity for certified nurse midwives, updated their regulations. These are just some of the advocacy organizations. I just wanted to share that with you just to show you we're just the common thread among the organizations is all organizations oriented to patient access to care, health equity, and social justice. So there's a lot of opportunity to work collaboratively, and we can get things done if we do it that way. And so these are just some of the things you can do to get involved. You can meet with your elected officials when they're in the district. You can write to elected officials. Usually these days that's going to be by email. You can attend town halls if they're having them. You can publish letters to the editor if you like to write. So what we do at AABC is we put together action alerts when it's time, it's time when we need a lot of support for something. So what we'll be having starting in early May is we're going to be wanting to add as many co-sponsors to the 3 bills that we're focusing on as we can, and that they need to hear from their constituents to know that that's important to you. So what we do is we have an app, a platform. We set it up so that you can click on the link and find out who your representative is, and then either get their phone number and make a call, or send them an email where we have, you've all gotten these, I'm sure. But if we get enough people calling, and it's really helpful if you know who your healthcare person is in your federal legislator offices, but also at the state level. Get to know your representatives and senator if you don't yet, because they want to hear from their constituents. Well, they have to hear from their constituents. They can't say anything about that. Okay, so I think the here's the contact information for AABC, and for the first time last year we had a National Birth Center Week, and so that was a proclamation in Congress. So we'll be doing that again this year as well. So I would just like to turn it over for questions. I have a couple of references here if anybody needs to look up any of the articles, but does anybody have any questions at this time?
There was a question about a birth center attached to a hospital is not a birth center. Can you speak to that a little bit?
Sure. And this is a great question, and it's interesting as well. I talked about how sometimes these days the birth center name, we didn't trademark it at the right point in time. So sometimes hospitals will just call their labor and delivery unit the family birth center. And that definitely is not a birth center. But some hospitals do have sometimes it's freestanding, sometimes it's in the same building. It's not considered a freestanding birth center if it's operating under the licensure of the hospital. That's sort of the technical way you can look at it. That means they're still billing. All their bills are being, all their charges are being billed under their hospital billing. There is a type of facility that can be accredited now by the CABC that's called the Alongside Midwifery Unit, or the AMU. They have these in lots of other countries. And sometimes they're called the midwifery-led unit. Sometimes they're called, but the name in the US that's typically used is Alongside Midwifery Unit. AMU. So this is where care is provided in the midwifery model. There's, you can get an IV there, but you can't get an epidural. you can't have continuous fetal monitoring there. You would have intermittent monitoring. It's much more of a physiologic birth, and it is limited what you can do. There's one of these on a floor of a hospital in St. Louis, where if the person needs or decides, if they need, let's say they need Pitocin because their labor is stalled out, they actually put them, move the bed, put them on the elevator, and go up to the labor and delivery unit to have that type of care, because they can't get that in the alongside or midwifery led unit. So it's a matter of accreditation and licensure of what that definition is. And so it's too bad because it's confusing to consumers, and they're not sure what to expect or what they're getting, because it may be called a birth center. And one way this came up was, states they monitor maternal mortality, and so there was a birth center in I believe it was Washington State. They were doing the maternal mortality stats, and they said, oh, there was a maternal death in a birth center. And it turned out that it was a hospital. And it was just a hospital that was calling its unit the birth center. So, it can become a problem.
That brings up a really good point. So are there different statistics for like the AMUs or the units that call themselves a birth center but aren't really a freestanding birth center? Are there studies out there showing
on the most of the data that are collected on birth in the US, we don't have a good data collection system. You probably are aware of that, but most of it's collected off of birth certificates. So birth certificates are pretty much standardized. There's still a couple of states that weren't collecting whether a home birth was a planned home birth or just a precipitous labor that happened on the bathroom floor that was totally unplanned. So I think all the states now have cleared that one up. But there are places to check on the birth certificate form. Was this a freestanding birth center birth? And so, as far as I know, the birth certificates have not added a place for alongside maternity or alongside midwifery unit birth. In Great Britain, they do keep statistics, I know, because they did a huge study called Birthplace Study that looked at outcomes in all of the birth settings, and one of them was the alongside unit. And so they could tell that the outcomes were better in the alongside unit than in the labor and delivery unit for low risk people. So it's a great question. We need to do better on our statistics, so we're not comparing the wrong things and getting inaccurate results.
Would you speak to what contributed to the increase in birth centers since 2010? Like the
Yes,
bigger increase.
that's a great question too. I think it was a combination of factors, but I really think there was a kind of a tipping point that happened with the growing demand and people being more educated about the option and requesting it, and a growing number of midwives who were not satisfied or felt like they wanted to provide real midwifery-led care, which can be hard to provide in a hospital setting, because you can just be more autonomous and more practice as a midwife in a freestanding birth center than you can with the hospital rules, regulations, and that overlaying of the medical influence in the medical model. So I think it was just that growth was just growing demand. Also, we have the American Association of Birth Centers 2 or 3 times a year puts on a workshop how to start a birth center. So I think that more midwives and other stakeholders became interested just through the dissemination of that knowledge about the model.
In the Strong Start study that you mentioned, you said 50% of people delivered in birth centers and 50% delivered in the hospital. What determined where they delivered? It was their choice, or how did that work?
So, so I should be able to, but I cannot give you a breakdown of those who needed to deliver in a hospital because of various risk factors or, situations in their health status. But a large number of people just chose to have a hospital birth. Um, you know, and I see this going forward. I see that we have a real need for more opportunities for people to have the birth center model of prenatal care, and then give birth where they choose. If they, if they feel, some people are still going to feel more comfortable being in the hospital as opposed to knowing that if something comes up, they'll have to move to a hospital. Now, myself, I had my kids at home back in the late 70s and 80s, and I was determined I was not going to go near a hospital because I was so concerned I might end up with a C-section. So, there's a whole spectrum of where people feel comfortable giving birth. And my philosophy is that people should be allowed to have their prenatal care and give birth in the setting that they feel most comfortable in. That's where they're going to have the best outcomes. Although we do have a growing body of research that we call the elective hospitalization research, where people who are very low risk, who could be admitted to a birth center in labor, just by the act of choosing to have a hospital birth, greatly increase their risk of having a cesarean, just due to the processes that go on in hospitals. But we did see in the Strong Start study that if people were properly prepared, they could really reduce their
Yes,
risk of having.
that primary C-section rate was very, very low compared to
It's
the rest of the
beautiful, isn't
country.
it?
It was. It
I know,
was.
when you look at the NTSV cesarean rates in the US, we can't seem to bring those down. But somehow birth center care does that. It just, it just prepares people to put off having elective interventions as long as
Definitely.
possible.
And the decrease in costs was also very interesting when you spoke to how birth centers decreased the cost per birth, and you said it was about $2,000 per birth. And I was thinking to
Yes,
myself, um, maybe in that birth, but downstream there are even more costs associated with that first C-section. And it brings me to this story of one person who had a bunch of C-sections and then ended up, with a uterine ablation and, low blood flow to the uterus. And then, it's not just monetary, it's also, you wanted a big family and now um, you're kind of stopped.
you're
It's,
limited.
yeah.
Right.
But then,
Right.
all these costs downstream,
Mhm.
when you have this huge, a whole bunch of people in the OR because you have accretia, like you have to have a huge staff to take care of that. And it presents risk to baby, it presents risk to the parent. And it's just, it's an epidemic.
It
Epidemic.
is. It is, and it is so dangerous too. Incretas and accretas are not fun for anyone.
So do we have more that we want to speak to?
Anybody have any other questions?
I do not see any questions in the chat.
Okay. Well,
Um, What
I-
one
yes,
question.
go ahead.
As a very low risk first time mom, I never considered a birth center because I thought they were just for hippies. I'm not a hippie at all, so it seemed like it wasn't for me. I just did not understand what midwifery was and why it matters. How can we make this clear to consumers? I don't want others to have to find out the hard way like I did.
Mhm, mhm. You know, I think that just the more we can disseminate these results and get them into the hands of people even before they become pregnant, the better. But a lot of people aren't really engaged in this subject until they're already pregnant. So um, um, I was a part of a National Academy of Science, Medicine and Engineering study on birth settings. That's really interesting to look at. It was published back in 2020. But the model that they talked about would be ideal would be every pregnant person actually has a session, an educational session early on where they hear about the benefits, risks, and options for all care provider types and for all birth settings. That is what they, what came out of that study that would really be a way to help people make informed choices. So I would love to see something like that develop over time. I take it every opportunity to go and educate high school health classes, but but again, it seems like the ones that are the age group that's more interested in kind of having the aha moment is about the sixth grade level. And they're nowhere near thinking about childbearing, but they have a very objective way of looking at things. By high school, it's hard to get them engaged in
Oh,
this
it's
kind of
interesting. So you've gone
health
to
thing.
you've gone to schools, to middle schools and high schools and spoken.
Sure. Yeah,
Do you
just
have a curriculum for that?
yes. Yeah, pretty much.
I'd love to connect with you on that.
Okay. There are all kinds of ways to advocate. But I think that the more that we can educate the general public about their options and the whys for choosing options, the better. But I am hoping that there will be more alongside midwifery units added to hospitals. It's really a good option for hospitals to add more midwife services to their facility, and it's low cost for them because they can bill the same whether somebody, pretty much the same, except for the interventions for someone who comes and has that kind of a birth at the hospital. But I think that is one way we can really grow access to midwives. And I think we'll always have a percent of the population, and apparently it's growing slowly, who's interested in freestanding birth centers.
And Jill is going to share with us these slides and we'll make them available to you. We'll have the webinar recorded and on our website within the next few weeks. And Jill will also share with us how you guys can get involved in contacting your representatives and officials so that we can get these bills passed so that we can have more access to midwives, because more access to midwives means fewer C-sections. It really does impact our future. And also a shameless plug, our feedback band database. We are building it again, a new one, and I need your help. We need your help. ICAN needs your help. You need to call. We need to have information from all the hospitals around to find out their VBAC ban policy, because lack of access to care is also a major epidemic in this country. We have to travel really, really far to get to the birth center in Virginia because I can't have a VBAC in Maryland, you know. So this is a big thing, and we need to have this information, and we need to collect the information. And there are about 3,000 hospitals, and we need help to get those called because we're all volunteers. And I know everybody, you know, if anybody can call 5 hospitals, we would love it. And then we posted the VBAC Band database link in the chat. And it's definitely on our website. It's on the front page of our website if you guys want to go and click on that. Thank you so much for joining us today, Jill, and everybody. And happy advocacy.
It's been an honor. Thank you. And also, when you call those hospitals, just because they say VBAC is available, you might also want to ask them how many they had last year, because they may just be telling you it's available, but it's really
Yeah, one of the questions in the questionnaire is, have any happened recently?
yeah.
You know, it's really, you know, if none of them have actually happened, then they can say that they do VBACs all they want, but that's not
But
the
they don't.
reality for people.
Right. Right.
Thank
All
you
right.
again for joining us.
Thank you for having me. I look forward to more communication and working together.